I'd like to take some questions in the time that's left, and I apologize for taking so long.
Oh, thank you. That was wonderful. We do have some questions. The first one is, the guidelines from Sweet Success that we use from 2011 state to do an A1C if earlier than 13 weeks. The chart that you just showed states 24 weeks. Has that changed?
Yeah, I think that's a local modification at UCSD. The problem is for the patient who either gets her first prenatal visit at 8, 9, 10 weeks, decides not to come back to get the A1C until later. What do you do with that? The IAD-PSG says as long as it's done before 24 weeks, it's valid to diagnose prediabetes and diabetes, and I would agree with that.
Thank you. Second question, are there studies where the A1C was used in early pregnancy for preliminary screening of GDMs or undiagnosed type 2?
No, and that's interesting, isn't it? And so we're kind of inventing something here, and in fact it's very frustrating to know that the standard deviation around a hemoglobin A1C that you get back, let's say you get back a 6.5, which is abnormal. Well, in fact, the standard deviation, if you had that woman submit 5 tests, it goes from 6.2 to 6.7. Heavens to Betsy. So she can be normal or abnormal. So I think whether hemoglobin A1C is going to stay in the game or be taken out in favor of fasting plasma glucose, we're going to have more studies from places like ours and places like yours who have actually studied this to see what the predictive values are.
Okay, thank you. What about doing the A1C at or right post-delivery?
Cool. I think that would be brilliant, except here's what we found out. We were hoping we could diagnose postpartum, 6 weeks post, hyperglycemia, because after the placenta's gone, within 3 hours the hormones normalize. So we ought to be able to check in the first couple days of the postpartum, and no, significant insulin resistance remains out to about 4 weeks postpartum. So darn it, you cannot use hospital numbers or even early postpartum numbers. You've got to wait at least 4 weeks.
Okay, why aren't improved long-term health outcomes from education done during pregnancy as being considered as improving cost effectiveness? It seems like this should be offsetting the increase in short term.
So 2 points about that. Number one is we hardly ever do what's long-term brainy smart, right? And so maybe the Affordable Health Care Act is going to make us treat episodes of care as part of a lifelong thing, and we're supposed to, it would be wonderful if we get there. Aaron Coy did a beautiful study of the cost effectiveness of the one-step test. And what his study showed is the one-step test was only cost-effective by gathering more people into the GDM fold if downstream health interventions occurred in that woman. In other words, now you're helping her understand her risk for downstream diabetes, and you put in place all these interventions for healthy lifestyle. That would make it cost-effective. But not, without it, it wasn't. So I think that says a lot about what we should be doing. But remember, you don't get paid for that, and so, ugh.
Okay. Should we be doing both the A1C and the fasting at the first visit, or just the A1C?
The A1C is the most convenient because you can send the patient right now, go to the lab, get it done. I think we're going to find out, we're already finding out because of the much narrower coefficient of variation around the fasting. That the fasting is probably more reliable, but remember I showed you the data about the abnormal hemoglobin A1Cs that almost 50% were on drug by 17 to 20 weeks. So I think for now we do them both. We don't, that's what, ADA says do one or the other. So if I find in my patient population, they go upstairs and get their prenatal labs done after we see them for their first visit, and they're not fasting. So they would clearly, but you have working women and other issues. So I put both on the list, and most of them do not get the fasting.
Okay, thank you. Fasting glucose drops about 10% by the end of the first trimester. How does this affect using the fasting to identify women who need intervention?
These are brilliant questions. No answer, of course. And how about this? Parenthetically, we find that these thin women with these paradoxically elevated 6.6 type of hemoglobin A1Cs have been carb gorging in the first part of pregnancy because their tummies were a mess. And I haven't done the proper, questionnaire with controls and all this, but I think it's quite possible that that first of all you have falling fastings in the early part of pregnancy that could confuse it, and that could get worse later. But remember, you're going to be tested later. And I think there's issues of carb loading in early pregnancy with some women with some pregnancies.
Thank you. Last question. Where'd it go? What are your thoughts on current medications for current gestational diabetes or treatment of gestational diabetes?
Normalize glucose and do it safely. So, that's a whole nother lecture, but normalize glucose.
Any preferences on how to do it?
No, the reason there are so many choices, there's a lot of different ways. I think the overweight woman is probably going to need to be on metformin for her whole life. You might as well start it now. Glyburide works well if patients have worries about transplacental medication drift, then use insulin. There's no evidence that one is superior for another. There may be a little evidence that babies treated with metformin, which is an insulin sensitizer, may have less body fat at 18 months, but that's a little not been confirmed. But an interesting idea that it's not bad to be, if you're destined to be fat, it's not bad to be exposed to metformin, but who knows?
I'm sorry, one more question. Can exclusive breastfeeding impact even infants of diabetic mothers' risk for obesity in the future?
None of the studies I showed you are controlled for breastfeeding, but the breastfeeding studies you all know about shows thinner babies with less obesity. So I think to take that latter factoid and make sure that to the extent possible our mothers breastfeed is critical. Remembering that, and I tell my patients this, remember if you're not in very good glucose control, the chances your baby is going to need to go to the NICU and get treated for glucose abnormalities is high. And that, for many first-time mothers, will torpedo the whole breastfeeding effort, the most important health event that can happen to this child. So normalizing your glucoses during pregnancy so your baby can stay with you and go right to breast is a gift that gives forever.
Thank you. That is it. Thank you very much.